So now it's my great pleasure to introduce Dr. Ma. Dr. Ma is a professor of neurobiology at the Harvard Medical School and a professor of neurobiology and cancer biology at the Dana-Farber Cancer Institute. He received his bachelor's degree from Fudong University in China in 1987 and his PhD in molecular biology from UCLA in early 1994. After postdoctoral training with David Anderson at Caltech, he became an assistant professor at Harvard in neurobiology and was promoted to a full professor in 2011. Dr. Ma's lab investigates the somatic sensory circuits, including mapping spinal pain circuits. Most recently, his lab started to map somatosensory autonomic reflexes as a way to understand how acupuncture modulates inflammation. His paper on this topic, published in the premier journal Nature in 2021, describes an elegant set of studies, which I imagine will be summarized in this talk today, which is entitled An Anatomical Basis for Electroacupuncture to Drive Anti-Inflammatory Neural Pathways. So without further ado, please join me in welcoming Dr. Ma. I'm very excited to hear his presentation today.
Hi, good morning, everyone. I would like to thank Peter for giving me this very special opportunity. So in this morning, I'm going to talk about our recent work regarding how acupuncture can modulate inflammation, systemic inflammation by driving a specific neuronal pathways. So I want to use this slide, a few slides to highlight how we started our acupuncture study. So I want this slide want to highlight some of the challenges, as you are a doctor probably know better than me. So regarding, we still face a lot of challenge to treat many chronic disease, like chronic pain for my life has been studied for many years. And also during this pandemic time, and we all deal with for those patients with a severe cytokine storm. So you can think about we had no great solution for a lot of those chronic, like a neurologic disorder or GI tract problem. So certainly there's many reasons leading to the difficulty to handle or to treat those kind of chronic disease. But I want to highlight one of the problems I think we may have been facing. It's called the presence of redundant disease-causing pathway or redundant symptom-causing pathway. So for example, let's use a pain treatment as one of the example. We know that beside the pandemic, and we also have an opiate epidemic in treating the pain, within the United States. And there are a lot of frustration in terms of basic science research in the pain field. Like right before the pandemic, the NIH organized a workshop to discuss why you guys have so many, sounds like successful stories in animal study, but very few those studies translate to new pain medicines. So like even last year, we had the Davy and Alden won the Nobel Prize for discovering the sensory channel receptor detecting temperature or touch. And that Davy's work in 1997, when he cloned the capsaicin receptor, it's really opened up molecular area for the pain field. Hundreds genes, I think, or hundreds genes identify associated with pain. And you recognize those, at the end, you recognize is just too many molecular pathways can drive the pain. And also at the circuit levels, similar thing, we're facing a lot of redundant problem. I will not go detail. So my lab has been mapping the spinal circuit and pain circuits in last 10 or 12 years. And one of the outcomes from that circuit mapping is recognized as just too many redundant pain pathway, like even at a spinal cord level or any axial level you look into it. Like in a spinal cord level, you have morphine sensitive, morphine resistant, pathway can make a inocular touch to become painful. So we're not good detail. So we facing the problem that those kind of have redundant pathway. And the second example is which many will talk about today is like the cytokine storm associated with those like during this pandemic time, like COVID-19 patient. So in response to the viral or bacterial infection, sometimes our immune system, the responses of the immune system too strong, produce too many pro-inflammatory cytokine that can cause collateral damage. And blocking those individual cytokine, it has not yet able to treat those severe forms of cytokine storm because of redundancy. Just like for the pain field, blocking those individual molecule or pathway has not yet able to handle many of those chronic disease, chronic pain, because there are just too many pathway and simultaneously can cause the organ damage redundantly. So this is a challenge I think we are facing. So how can we deal with this kind of complex disease or has a redundant symptom-driven pathway? So I think that one of the potential hope emerging during the last 10 years, I think that many people try to study disease at a more like a system physiology level, like by particularly with a particular focus on nerve immune target tissue interaction, for example. And those kind of study, almost touch every aspect of a chronic disease, from cancer progression and then to, of course, for the pain as well, anything, all the neuronal brain like disorder also involve the immune and nerve immune interaction. So from those kind of interaction, people start to look for some kind of like a more higher order control system, like some kind of nerve signal, which maybe, for example, in terms of inflammation modulation, it's not deal with one cytokine, and those high order control system may dampen the immune system activity to control a larger number of like a pro-inflammatory molecules. So this is the kind of way is also not just deal with the symptom, for example, deal with individual cytokine, but also deal with the sources driving those redundant disease causing pathway. So this is I think rapidly emerging, there's a system physiology approach. I'll give you example, like for example, in terms of cytokine storm control. About 20 years ago, Kevin Tracy really made one of the pioneer, like a landmark discovery, when he shown that the vagal nerve stimulation, which at that time is FDA approved for treating those severe forms of depression or seizure, but he found that the vagal nerve stimulation in the neck, can drive those some sympathetic or autonomic pathway to can systematically reduce systemic inflammation, can greatly promote animal survival, at least in animal study. We now know that the autonomic system is divided into those parasympathetic and sympathetic, virtually control every aspect of our body physiology. So the question is, if the nerve immune target tissue interaction plays such a critical role for disease progression or even for potential disease modulation, but the question is, how can we modulate those autonomic pathways? The vagal nerve stimulation is invasive and also lacks specificity to drive the very complex, distinct autonomic pathway. So the question is, how can we mobilize or stimulate those autonomic pathways? So this is a time, this is a question leading to, I think, a great, idea exchange between the Western medicine and some of the traditional medicine, and which today we talk about as acupuncture. So one of the core idea, of course, acupuncture, you stimulate the body somatic tissue, somehow, some way can distantly modulate your physiology, like acupoint in a Zhushani or in a leg, can somehow can promote like a gastric motility. And the people, this is one of the foundation for acupuncture practice. And by how to explain and this acupuncture, you know, how that acupuncture can work distantly. And I think for people working on acupuncture field, it's hard to ignore the Meridian channel hypothesis. So, and it's still very controversial. And but if you look at what's the core idea? One of the core idea about this Meridian channel hypothesis is supposed to be one of the vehicle or the substrate that connect, you know, all body parts, such that in a way, when you stimulate in the trunk and limb region or any somatic tissue, some way, somehow can influence the internal organ. So I think the last 100 years, you know, from Japan, Korea, China, try to look the physical substrate, well, you know, to say, do you have a channel like that? But no one clearly, you know, see anything like that. But so because of that, there are a lot of doubts and about the whole some of the foundation about acupuncture practice. That's even in China. I just told Peter before the meeting, you know, one time I attend a China committee, someone present acupuncture functional imaging study, and one of the very prominent Chinese scientists, his comments say, whoever believes in acupuncture is not a serious scientist. So I told him I'm one of them. So, but in today's talk, I want to, you know, introduce you know, the somasensory autonomic reflex. I think this system is providing a vehicle for acupuncture to distantly control physiology. So my lab studied those somasensory system for the last 20 years to study somasensory like pain, itch, transmission. But we know that somasensory has a functional connection with autonomic nervous system. Like in response to any painful stimulation, we know that can activate sympathetic to increase heart rate, for example. And when you, after you're dealing with a threat, when you have body injury, you will calm down and, you know, to promote parasympathetic, you know, to promoting the wound healing or those kind of things. So this, but a very few study actually in our field, we call it the autonomic dimension of the pain. We know that that dimension exists, but very few people really studied make this connection. How the somasensory stimulation can make a functional connection with the autonomic system. Now you can long distantly modulate body physiology. That's exactly what the Meridian channel or acupuncture, you know, practice propose. You stimulate the body, somatic tissue can long distantly modulate the body physiology. So this is our entry point to get into the acupuncture field. In some sense, it's to study the autonomic dimension of the pain. So for many years, we mapping the spinal circuits as a basic idea how we study acupuncture basis. So we use a genetic tool to manipulate sensory neuron, autonomic neuron, then to study how that manipulation will impact on acupuncture effect. So the one of the model system we study in animal is because you need a robust assay anytime you want to study. One of the robust assay turns out it is a cytokine storm management pioneered by Kevin Tracy and many people, other people like Louis Wula, Bing Zhu, or Xiangrui Wang. And what this acupuncture stimulation can reduce the cytokine storm, you know, dramatically and greatly promote animal survival. And this assay is very robust. So this is the assay we use. So we have a genetic tool to manipulate neuron. Now we have a robust assay. Another assay I didn't discuss is the gastric motility assay. So use this assay, now we can study what's the neural basis underlying acupuncture practice. And so this is a two paper we published. We started the work in 2016, and we published 2 papers now. And and those 2 papers show that acupuncture practice does have some neural anatomic basis. So many factors can influence acupuncture effect, including like body regions. There is some kind of body region specificity. Will touch the core idea behind acupoint selectivity or specificity. It's also intensity dependent, which I not talk about too much, or disease state dependent. But today I will show some of the basis behind the body region specificity. And this idea actually is not, in terms of scientific research behind the body region specificity in driving the somatosensory autonomic pathway, actually is pioneered by Acusato, Robert Schmidt in late 1970s and early 1980s. They studied at that time to study the gastric motility control. And they use a painful pinch stimulation and study how the pinch will impact gastric motility and produce, which I think is an iconic, body map. It's not acupuncture map, but it's showing some flavor. What this map showing that is the dark spot mean that inhibition, gastric motility. Open circle is mean the promotion. You can see the same stimulation, same input can produce opposite output in a different body region. With the limb region can promote gastric motility, which require gastrophageal efference. What the limb region or the abdominal or lower thoracic region will inhibit gastric motility by driving gastric sympathetic reflex. And Professor Bing Zhu in China, they essentially reproduce what is Acusato's finding by use electrical acupuncture. You can produce the same acupoint map or basis body map. And this study is really showing that for me, when I learned this story in 2014, 15, when I first discussed with Bing Zhu, and I told him this is a great entry point. Now you have the same input, has opposite output, driving different autonomic pathway. That's a pure neural anatomy question. If it's a neural anatomy question, we basic science, work on neural anatomy should be able to study or to solve this kind of problem. So in the first paper we published, actually showing that one of the vagal somatosensory pathway discovered by Luis Ula, published in Nature Medicine in 2014. This is called the vagal adrenal axis. And what happened, this axis discovered by Luis Ula, showed that he stimulate hindling region like a ST stomach 36. It's acupoint just below the kneecap, and then through the anterior tibialis muscle. And you can drive the sensory pathway, send signal to spinal cord, to the hindbrain, then generate those vagal efferent output neuron, like a parasympathetic efferent neuron. And this efferent can cause adrenal gland to release catecholamine to reduce the systemic inflammation induced by bacteria and the toxin like LPS. And what we find in this paper is showing that it's just like Acusato's work. This pathway has acupoint selectivity. You can do it at a stomach 36, even with a low electrical intensity, but you cannot do it in the abdominal region. I'll show you a few slides. So here's what we did. In mice, use a pale electrical needle separated with 1 millimeter. Insert through the ST36, analogous ST36 region, about 3 millimeter into the anterior tibialis muscle with the needle tip very close to the deep peroneal nerve. And this 15 minutes acupuncture electrical stimulation can activate the vagal efferent neuron by C-force induction, even with a low electrical intensity. And we can also show some of the C-force pulsing neuron project to the adrenal gland. And when we cut the vagal, and this electrical stimulation, as reported by Luis Ula, can reduce the systemic inflammation, including all the cytokine we examine, like TNF-alpha, interleukin-1 beta, IL-6, HMGB1, those cytokines all reduce. And this anti-inflammation effect is dependent on vagal efferent. So if you cut the vagal nerve, this anti-inflammation effect will be lost it. And without going detail, we also shown that this pathway also requires adrenal gland. So if we use a genetic tool, selectively remove a subset of chromatin cell expressing a neuropeptide Y, it's an NPY pathway chromatin cell, and this anti-inflammation effect will be gone. So basically, the vagal adrenal you can generate from SD36. You can drive the vagal adrenal axis, but if you do this at a stomach 25 in abdominal region or any abdominal region, even high intensity electricity, you cannot induce C4 in a vagal, parasympathetic efferent neuron. And when you use a low intensity stimulation, which can reduce inflammation from hinding region, you cannot do it in abdominal region. So this is really showing that there is some kind of acupoint selectivity. So at this point, it just repeat what is Acucyto's finding. He's measured gastric motility. We measure the anti-inflammation effect or vagal adrenal axis. There is acupoint selectivity. So the question is then become why the vagal adrenal axis, can only evoke from the hind region. So that's back to the 2014-15 when I'm discussing with the Professor Bing Zhu. So then what's anatomy? So my lab is actually developmental biology lab, and we know the nervous system is one of the major anatomic organizations, the rostral caudal. From full brain, also we caudal spinal cord, we know that has a rostral caudal patterning. And some of them like a motor neuron only in the limb region, but not in the thoracic region. Preganglion neuron to sympathetic ganglion only in the thoracic region, but not in the limb region. And the more recent, David Ginty, our colleague in the neurobiology department, do the single cell sequencing to characterize a cell type along within the dorsal lunar ganglia. You can see some neuron enriched in a thoracic region. Some neuron were enriched in a limb region. So basically, we hypothesize that the vagal reflex must be somehow driven by some sensory neuron selected innovate those limb tissue, like a bone, skeletal muscle, joint, that not present in the abdominal region. So that's the idea we are looking for. I mean, without going details, this is really come from deep from our developmental biology background. So many before we map in circuits, my last study in neurodevelopment, we discovered so my central system is organized. One is a go-to two major branch. One is a go to skin epidermis for defensive reaction. The other branch is innervated throughout the body, which is for monitor body integrity. And including for the deep tissue innervating neuron, like in the limb regions, those are deep fascia. So we're looking for those molecular marker innervated deep fascia neuron. Hopefully we say we can see some unique sensory neuron can distinguish the hinding region from abdominal region. So we screen through a dozen or half dozen crinoline, eventually find one of the crinoline, we call it ProKI2, Cre marked sensory neuron. And this group neuron, we published a paper, is required to drive the vagal adrenal axis. This is a prokinesin 2 receptor. The name is not important. And so this group neuron is really mark a subset sensory neurons. Most of the neurons express a nerve growth factor receptor tract A, 60% are myelinated. They are not proprioceptor, but also they are not colloquial with those almost 50% DRG neuron labeled by IB4, which only innervate the skin, epidermis or hair follicle. So it's a unique subset, tract A lineage neuron. And when we look at the distribution of those neurons, then now we see this neuron in terms of percentage-wise, say enriched in the full limb and hinding, and but much less in a thoracic level, almost fourfold enrichment in the limb region compared with the thoracic level. And then we look about the innovation, and then we find that this group neuron is really quite interesting, and they include those myelinated prokaryotic label neuron. This is a fascia tissue, in our body, like when Helen, Langevin, she was here, and she was one of the pioneers of pushing forward, say, fascia tissue stimulation is a part of the acupuncture foundation. And we know those tissue is really enriched for the sensory, sympathetic, and autonomic neuron, lymphatic tissue, and immune cell, fibroblast cell, all those kind of tissue. But we recognize our neuron is selected innovate some of the fascia, but not all of the fascia. For example, in the limb region, very dense innervate to the bone periosteum, joint ligaments, and plantar fascia, and virtually almost all of the fascia tissue within the limb region. But it's not innervate fascia in the abdominal region, like a peritoneum, or the most of the muscle, abdominal muscle, those are very rare as innovation. So this has with enrichment in the limb, and enrich the innovation to the limb fascia, and not innovating to the skin epidermis. So we thought this group neuron could be candidate to drive the vagal reflex selectively from the limb region. So without going detail, we have a genetic tool to selectively to remove those prokaryotic marked neuron within the DRG. And so Cree can in the brain, spinal cord, and other tissue or skin tissue, but we have a genetic trick, allow us to very select manipulation only in a sensory ganglia. And then we can study without this neuron, now we can test how acupuncture effect will be impacted. So again, we do the ST36 electrical stimulation, which normally can induce C-force in a parasympathetic efferent neuron in the hindbrain, and this induction very much abolished. And this stimulation will causing the catecholamine release from adrenal gland, and this release without this group neuron, acupuncture effect is again by this low intensity acupuncture stimulation. High intensity to the different business because we recruit many other autonomic pathways. So this low intensity, again, acupuncture effect lost it. The anti-inflammatory effect was abolished without this group neuron. And we also can do the genetic trick to do the gain of function study. We introduce a channel rhodopsin gene expression only into those prokaryotic sensory neuron. Now we can insert the optic fiber into the ST36 region. It's almost like optoacupuncture. And this optical stimulation, this group sensory nerve fiber can sufficiently activate, drive the vagal nerve, and a vagal reflex by electrophysiology recording, vagal nerve recording. And this optogenetic stimulation essentially mimic acupuncture, electrical acupuncture, can reduce systemic inflammation in a vagal nerve dependent manner. And can greatly promote animal survival. You can see just 15 minutes stimulation and can increase animal survival rate from 30% to almost 80%. So we this part study showing that prokaryotic neuron, which innervates a deep limb fascia in the limb region, who are both necessary and sufficient to drive the vagal adrenal anti-inflammatory pathway. And it was also interesting, now we can come back to take a more closer look at the nerve distribution of this group of neuron. Based on the distribution pattern, can we predict in the body region effective or not effective for acupuncture to reduce the inflammations? So remember this group neuron also enriched in the falling region. So when we stimulate put a needle close in the falling, close to the deep branch of the radial nerve, which also innervates the bone periosteum. And you can also produce anti-inflammation effect in a vagal nerve dependent manner, and also depends on procreative neuron. And I remember the abdominal region, I showed you, there are no innovation to the abdominal peritoneum, and also fairly rare innovation to the abdominal muscle. The density compared to anterior tibialis muscle, it's almost tenfold difference. And then when you insert the needle into the abdominal region, it has no effect, no anti-inflammatory effect. And this is sometimes I think it's not says all the Meridian channel acupoints, it has you don't have to, not necessarily believe, has all those acupoint specificity, but still, I think sometimes you will surprised, or you will be amazed by what those Asian people did. Here, if you look at the posterior part of the hind leg, from the side to hind leg region, and you will see that this is blood channel which contains acupoint along the midline of the posterior side region. And this is what here where the sural nerve are located. The ST36 is really located along those deep peroneal nerve, very close. And this is the sural nerve are located region. And in each side of those the sural nerve, and here's a big belly, a big muscle, gastrocnemius muscle, or like a semitendinosus muscle. And you do not have a traditional acupoint. In fact, a lot of acupuncture study use this, from the midline away and into the gastrocnemius muscle, used as a non-acupoint control. And this is really, I think, is quite amazing. And then when we look the innovation within the gastrocnemius muscle, it's a fairly sparse innovation by O1 neuron. Compared to the inner compartment within the anterior tibialis muscle, again, it's a tenfold difference. So soleus muscle has which is considered a deep part of the muscle, has a much more innovation, but as a gastrocnemius muscle has a fairly minimal innovation. And then when you put the same needling vertically 3 millimeters into the gastrocnemius muscle away from the midline here, and then it has no effect. And the same thing for the semitendinosus muscle is also very sparse innovation, and acupuncture has no effect. So another issue is about acupuncture is called needling the depths, how deep you put the needle into the muscle. And this part actually I discussed a lot with one of the professors from Beijing Institute, traditional Chinese medicine, Beijing University of Traditional Chinese Medicine. And then, so he's, one of the crucial acupuncture stimulation parameter called the layer hypothesis. And back to our developmental study, we know that neuron go to the superficial skin versus neuron go to the deep is two fundamentally distinct sensory systems, actually. So this is we don't, in the audience, you remember back to when we tried to build that TCM center at Harvard Medical School, we failed, and he's one of the panel member visiting us. I discussed with him, and he introduced this idea. I told him, saying, I can partially explain the depth dependent because the sensory system go to superficial body for the deep tissues are very, very distinct. And if you look at even within the muscle, remember our neuron didn't innervate skin abdominis. Even within the anterior tibialis muscle, within ST36, the inner compartment and outer compartment are very different muscle. Because the inner compartment, just like sonus muscle, has a slow twisting muscle fiber, while the outer compartment is do not have. So this is a functionally distinct compartment. And O1 neuron has a very dense innervated deep compartment, but not the superficial compartments. So now if you put a needle right underneath the skin, instead 3 millimeter deep into the anterior tibialis muscle, you cannot produce anti-inflammatory effect. So what I told you today, basically, based on this anatomic study, we discovered a group neuron has shown the deep innervation to the deep fascia surrounding the bone periosteum, or the muscle contains a slow twisting muscle fiber, those are deep muscle. And this surrounding the bone has a dense innervation with a cutaneous skin epidermis, or the outer muscle compartment from the gastrocnemius muscle or semidentate tendinosus muscle, and all the outer compartment from anterior tibialis muscle. Those are very minimal innervation. And you need to go deep into the limb region to drive this, when you, in terms of low intensity electrical stimulation, to drive this vagal adrenal axis to produce anti-inflammatory effect. I do not have time to discuss the other factor influence acupuncture effect, which are published in a Neuron paper in 2020, showing that to activate other autonomic pathways like a splenic adrenergic pathway, you need a high intensity. And this high intensity can drive this pathway in an acupoint independent manner. Both ST25, ST36 can do it. And by that, noradrenergic can produce anti or pro-inflammatory effect based on the different disease state. But I will not go into detail. So basically, in summary, what I shown that acupuncture does have some anatomic basis. There's a crosstalk from somasensory to autonomic. It's a very, very complex system. It's a crosstalk between two very complex, neural system. You still need a brain integration. And this is a three-dimensional organization from a different layer, different rostral cortical organization, meaning that it has a anatomic basis for acupuncture, stimulating a different body region or different intensity, different depths, can produce different kind of autonomic pathway to distantly to modulate body physiology. And this study is really a fruitful collaboration between China and the United States, which unfortunately is much harder now for us to continue. I told you that the Professor Bing Zhu introduced Acucyto's work showing the iconic body map by pinch. It's really showing the limb region, abdominal region difference. It really provides a fairly important entry point for us to figure out, as a starting point to figure out to map the unique somasensory autonomic pathway. Yanqing Wang in Fudan and Xiang Hongjing as the current president of Institute of Acupuncture and Moxibustion in Beijing, and they sending the first generation student and postdoc, Shanbing Liu, Yangshuai Shu, Qiufu Wang. He's come to my lab to set up the acupuncture study in 2016, and other student help and postdoc help. So I will stop here to answer your question.
Well, Dr. Ma, thank you for such a rich talk, really bringing together such remarkable knowledge you have from neuroanatomy and molecular biology to address some really puzzling questions that live between the intersection of traditional East Asian medicine and Western biology. So it's just fascinating. And your studies are, your presentation was so clear and so understated, because each of the graphs you presented probably represent tremendous amounts of trial and error and work. And so it was just a really accessible presentation. There's lots of acknowledgement for your work. Thank you for your amazing presentation. Many people are sending notes. And then there's some really good questions. So I'm hoping you'll be willing to take on a few of these.
Sure.
One of them that we've been thinking about in our lab, and especially Eunmei Yang's work, but Weidong Liu and others, is, now that you have this understanding of neuroanatomy and neurophysiology, what are your thoughts about the use of, and this is translating into clinical trials, that knowledge to determine what a good sham point would be as a control in a clinical trial. Can we use this knowledge to pick places that are relatively more or less inert so that we can translate these questions into more human studies?
Yeah, I think that's yes, thank you, Peter. I think that's a great question. Yeah, I think one thing because we did it in an anesthetic condition and it clearly showed there's an anatomical difference. And then like based on this anatomic based effect, certainly I think you can see the acupoint assay studies or the gastrectomy muscle right in the middle of the belly has a clear difference if you as in terms of sham point to choose. I think but in a series, there is some challenge, I think, in terms of clinical trial, a clinical study. For example, when the pandemic started, we discussed, we wish we can test the cytokine release syndrome for the patient, like use a low intensity electrical stimulation, which can reduce inflammation almost in a disease state independent manner, not like the high intensity can beginning so good, but later can make disease worse. And so we can do some human study. We don't, we discussed several times, but we have not yet has a resource, to engage this study. But I think on other hand, we may facing some other issue and do the acupuncture because Peter, a lot of time one of the major criticisms was a sham stimulation or real stimulation. Sometimes the difference is not as big as like in an animal study here in an anesthetic condition. So I think that's raising one of the, I think, a huge problem for the acupuncture field, or because you can think about when do the clinical trial, original idea is the placebo effect is the mechanism is non-overlap, so that you can isolate the real effect by subtracting the placebo effect. But what if, now we are talking about autonomic nervous system, but what is all the placebo, if you go to Weidong's acupuncture room and there's a musical, quiet, nice, sitting, practice, receiving sham control for certain minutes, I think it will change a lot of your autonomic nervous system as well. So maybe could you mimic some of the effect you see, like producing those autonomic or reducing myostatic activity or increase some parasympathetic activity. So that how we can overcome that challenge to really, because I think this is one of the challenges I'm thinking when I work on this autonomic system. I think the RCT people say that's a golden standard, but I think that's some problem we are facing. Yeah.
There are a lot of questions about this translation to humans, and I don't want to put you on the spot or make you give away your best ideas for future research, but do you have 2 or 3 questions that if you had resources, where would you start translating this work into either clinical or preclinical studies with humans that are obviously ethical?
Yeah, I think just like I say, we discussing, like, for example, when we here at the Dana-Farber, one of the major side effects associated with cancer immune therapy is a cytokine release syndrome, which is limiting a lot of the CAR-T or some immune system. So Weidong is doing for treating the side effect associated like pain, neuropathy, associated with chemotherapy, but I think we should hopefully in the future we can test some of the electrical stimulation parameter like we discovered in mice. 0.5 milliampere. My belief is not painful. I tested in my leg is maybe a little bit of sharp, a little bit of sensation, but it's not painful yet. I think maybe it's a non-painful intensity stimulation. Can we measure some of the catecholamine release in a serum, for example, in human? And can we engage those cytokine release syndrome like one of my friends in China, he's doing those clinical trial on the CAR-T or related. He said, we have such a high percentage of patients with cytokine release syndrome. And I say, can you help with your acupuncture stimulation? I think in the future, we hopefully, has a resource to test it, do some like a clinical trial. Can this low intensity electrical stimulation can help to reduce those cytokine storm, and whether or not our stimulation can really to treat the actual real world like a infection, like a bacteria or virus, and because those need a fine tune inflammation, because you cannot, need the right balance, not causing organ damage, collateral damage, but at the same time you have to maintain the immune system activity to fight the infection. So those need a more human study, need a clinical study. So we hopefully has a collaboration opportunity. Yeah.
Fantastic. I'm going to shift to a more basic question. This is one of your colleagues who's had a long history of doing some of the early work at University of Maryland, Li-Xing Lao. And his question was, how would you comment on earlier studies conducted at University of Maryland in which acupuncture at hind limb acupuncture point, namely gallbladder 30 or Huan Chao, could activate the HPA axis through stimulation of PVN in the hypothalamus, which could also trigger the release of cortisol in the adrenal? Is this a redundant pathway, or is the vagal pathway the only pathway?
Yeah, I think that's also a great question. I think we have preliminary data showing that this low intensity electrical stimulation, even this in anesthetic condition, we theoretically remove some of the those stress or because but I think also can appear to be cause a cortisol release as well, beside the catecholamine, and so. But still, when we give the pharmacology, of course, it's not a very clear cut. We use Luis Ula at Duke now, and he's discovered this pathway when he gives a dopamine D1 receptor antagonist, somehow can block the acupuncture effect, because for this vagal adrenal, they particularly cause a release a lot of dopamine, which is kind of unusual, because normally it's like adrenaline is dominant. And we repeated his finding is a D1 receptor can block the acupuncture effect. But a D1 receptor, those antennae can cross brain barrier and all those things, interpretation is very difficult. So, and to what degree the cortisol contributing, or does a D1 receptor can impact a cortisol release or not, we don't know. So it's the fine detail still unclear yet. Yeah, it will be interesting to explore. Yeah, but in a human study, hopefully, like acupuncture, we don't make, when you treat a patient, maybe don't at the beginning give them too strong stimulation, make them feel acupuncture mild, and so this is not big deal. Then maybe they were less stress or something. So it's we needed to discuss. Yeah.
Yeah. Well, as I shared with you, Dr. Liu is one of my doctors for acupuncture, and he's been testing your protocols on my body, and the stimulation is acceptable. It's not
we should collect some of your blood sample. We want to test the catecholamine release.
It's not research. It's just little N of 1 clinical experiences. Okay.
Yeah.
But I want to go back. Broaden this, because we have people in our community that are studying lots of interventions that I think are equally in interface with mechanical stimulation, and of course here you've added electrostimulation. But it's intriguing that you've used laser, electrostimulation, manual stimulation, and that there could even be optical effects, that affect these deep nerve receptors or deep tissue receptors. And Helene started with looking at connective tissue and needling, and then expanded her work into all sorts of yogic kind of stretching. And so I'm curious if you step back a little bit, what's the potential for things like Tai Chi, yoga, other forms of movement or changing in posture that might be able to activate some of these pathways?
Yeah, I think this, Peter, thank you for for this question. So I think that this like Helenki study does the fascia tissue. Helen focus on some part of when he twisting sees a more like a fascia is a network, even showing a more longer distance effect than just a little bit local, like it's a tension created when you deal with fascia tissue. But and also we believe that the neuron we are studying must be mechanical sensitive, because they innovate really virtually every limb region from toe all the way, the ligaments, many ligaments has a very dense innervation of our neuron, and including the plantar fascia. And so we think that one of the future study we want to test is the yoga stretch or Tai Chi. I practice Tai Chi actually, a little bit. So I think that we believe they will activate our neuron, and so we will. That's one of the things we really want to hope to test. So maybe a lot of people call alternative medicine, but maybe has some share mechanism a little bit.
Yeah.
So it will be really interesting for us to test, but we have not done too much yet.
Well, it's interesting hearing the innervation of the plantar fascia, and you know that here in the U.S., especially in metropolitan areas, foot reflexology places based on Tuina are increasingly popular, and they have you see people walk in that are not really exposed to alternative medicine, but they soak their feet for a few minutes and they get 45 minutes of foot massage, and they look completely different when they walk out. So there may be some of those somatotopic maps that we know. You see these maps of the foot that are sort of holographic, and it would be interesting if indeed some of the mechanisms you're talking about manifest in these foot maps or palm maps. That would be another way to use these paradigms to sort of bridge these traditions.
Yeah, I think that's one of the area we definitely like foot massage is so popular in China as well. You know, from some of these big major, so a lot of business there. So it's I think this is the opportunity for us. Hopefully some of the physical tool you mentioned, like a laser and other mechanism, because different modality, like even the manual acupuncture, the initial maybe you stimulate a mechanical sensitive, like a nerve, or like Helen even say like a fibroblast cell or some other cell. And the other thing is when you twist in the needle, you have an injury. The injury, the releases a mediator will activate other mechanical insensitive fiber. So we call it silent mechanical nociceptor. After the injury of a while, then they can gain the mechanical sensitivity. So mean that it's a dynamic stimulation process. So each stimulation modality will produce a different spectrum of sensory afferent activation in a temporal spatial manner. So I think that a lot more study for us to, how different modality of stimulation can generate a different spectrum of sensory afferent, can drive maybe preferentially driving different autonomic or different output. So
well, I think this is fascinating, and these tools, and I think this is the spirit of the Osher Center and many people doing integrative medicine basic research is, can we look at the premise of these traditional therapies, understand the biology, and then make it more accessible, more efficient, maybe even more effective clinically by understanding mechanisms. And I think that there really is a lot to learn. There's a lot of wisdom in the past, but there's a tremendous amount of wisdom in our current, the resources we have in modern biology. And I think the two together are really strong. So one of the questions was, does it matter what frequency electrostimulation you use? And we know from good research that different frequencies can have very different effect, as you're saying. So you're answered that question.
So far for this vagal adrenal pathway, we test the different frequency, and it turns out do not has a dramatic difference. We tested, but we know the frequent, like Jiseng Han in China, and one of the major pioneer acupuncture research in China, he and other people shown that different frequency stimulation can cause the release of different opioid peptide. And so he used alternative like low and high frequency conjointly to achieve some more like a optimal effect. And it is true for neurobiology point of view, we know the frequency is one of the hugest thing in terms of neuron firing. Like some of the C fiber, for example, you cannot follow high frequency, while A fiber you can follow high frequency. So I mean that different frequency and some neuropeptide release, maybe you need like sometimes high frequency, for example, bursting firing to produce a peptide release. So there is a neurobiology language, activity can influence by those stimulation parameters. So at the end, I think here we only touch one pathway, like a vagal adrenal. I think that depends the outcome you measure, maybe will be different, like a different all different parameter needed to optimize. So I try to argue with the TCM field. I say acupuncture specificity is kind of really operational definition. It really depends on what you measure, what kind of outcome you measure. Then we bring the all different kind of intensity or frequency or location.
Super. So I'll close up here. We're at time, and thank you for such a remarkable presentation, really leading edge thinking and taking such complex ideas in some ways and making them so accessible. And thank you so much for taking the time to do this. And we look forward to ongoing collaborations. And a few announcements to the general community as we end here. First, we hope you're going to join us in 2 weeks for our special grand rounds to mark the 20th anniversary of our Osher Center. The event is entitled From the Foundations to the Future. It's going to be on May 17th, and it's going to be from 10 to 11:30, a different time. And it's going to be a hybrid event, both taking place in person at Bornstein Amphitheater at Brigham and Women's Hospital, and also online via Zoom. And on June 7th, our next regular grand rounds, which will be starting at 8 a.m. again on Tuesday, our very own medical director and associate clinical directors, Dr. Don Levy and Matt Kowalski, respectively, will present a clinical case entitled Integrative Medicine for Chronic Pain, Going Beyond the Toolbox. So you can learn more, register for these events, learn more about our programs, view archived grand rounds, and even make a philanthropic donation to support our Osher Center at oshercenter.org. So thank you all again for joining us today, and especially thank you to Professor Qiufu Ma for presenting his remarkable work.
Thank you very much for all the great discussion. Thank you very much. Yeah, really appreciate it.